If we're going to be using quotes and aphorisms, there is one that strikes me as encapsulating this day in some ways. I first heard it from my colleague Stacy Chang, who's at the University of Texas in Austin. He said, "Healthcare is a planet that thinks of itself as the sun," and I think we are beginning to see that doesn't always have to be the case. And I want to commend the planning committee and all the presenters who really did a great service to humanize and set a new standard for what the practice of institutional change is. All of you are working within institutions that, their default mode has been to do something else that was positioned as the center of the universe for a long time and is greatly funded to do that, but isn't really delivering the outcomes that we want. And the tipping point that I think Josh was talking about is in the rearview mirror. I mean, there is a lot of momentum to say that business as usual is going to change. And what we've seen here today is a nice mosaic of examples of how people are beginning to do business differently in real ways. If I have any thirst for more here, I think what we heard was the near edge of stories that in some cases are just a few years into the work, and in others are marrying with infrastructures that have been around for 30 years and are just beginning to see that there's a lot more value to be brought together. So the nature of the stories we heard today, I think, are the front edge of this. What would be really fascinating is to marry that with what each of these groups and others like them see as where is this going, right? We didn't talk so much about the full expression of this, so that there's something of sort of pushing factors that are propelling this work into what it looks like now. But I'm a little bit, I would suppose that we need much more attractive pulls, right? That the magnetic reasons to produce better well-being and to have that well-being be more fully attainable for everybody, no exceptions. What are the conditions that allows that to happen? I don't think we heard quite enough about that today. But my hunch is that all the speakers have a vision of that we just didn't get out, and it's a big part of the organizational change stories that we're hearing. They're going to make you come up over here, Gary, so you got to come on.
Do I have to go over there? So thank you to the planners and to the panelists, many of whom came a long distance and interrupted really important work to share their perspective with us. 3 quick comments. I've been moved, like many have recently, by a 16-year-old from Sweden, Greta Thunberg, who, when she addressed our colleagues working on climate, in a very straightforward way said, "I'm sorry, you're not trying hard enough." I don't think we're trying hard enough. And this is a field that has matured and long enough to know that we're not trying hard enough to actually change the fundamental drivers of health at population scale. So I'm sort of left today with a sense as a grown-up in the field thinking, I'm just not trying hard enough. we gotta like do way better. To the places where I think we are missing in our analysis that allow us to think we're trying harder than we are. One is the social nature of the social determinants. And so I was sort of disturbed by the map that we laid out, in the sense it was teasing us into thinking these are way easier phenomenon to engage. And social phenomenon are social, they're not mechanical. We have friends we work with who are pretty clear that community is more like trying to map the mind than it is like trying to assemble tinker toys. And maps of the minds, those of you who are neuroscientists will know that you can trace the neurons and actually not go very far in understanding the phenomenon of consciousness. And health is more like the fruits of consciousness of a complex human system than an array of interventions that add up to be countable as outcomes. So I think we're dramatically underestimating the the assets of social complexity as well as the challenges of social complexity. The second, I'll stick with the word assets. One of the shocking moments today, we had one of the very best chief financial officers in the entire field of big-time healthcare with us today. And it was quite striking to me that he had never thought that there might be the possibility of policy folk changing the rules of his playing field slightly so that he could be able to think more creatively about $9 billion that has been accumulated by an extremely value-driven, well-run organization. And he had just never thought about that. Well, we need to really think hard about that. There surely has to be some way to put in motion these deep wells of funds that are held in healthcare and get our mind off the marginal, they're not for profit, so you can't call them profit, but the margins of these systems that are relatively modest compared to the deep wells of investable capital that actually line up gorgeously with the social determinants, with the needs of our web of social partners, with huge big-ticket items such as housing. The pools of funding are actually there that are right now locked. And it's very significant that the people managing those funds haven't even thought that we could help change some of the rules of the playing field so that they could think that way more positively.
It's a race.
Go ahead.
Thank you. It's interesting. Josh made that comment about people come to Washington and you just can't get them to stop talking. And, here I am at the lectern, and this is pretty cool. Yeah. As many of you know, I've been on the roundtable since it started. And as many of you know, I've changed jobs a few times and moved. And what happens is, you end up with these big boxes of old things. And just recently came across this box of very old reprints that I've had forever. And I came across this article by Archie Cochran and Arthur Bradford Hill that's more than 50 years old. And one of the things they say in it is they say, well, if you want to figure out if things work in medicine, you have to ask three questions. The first question is, can it work? The second question is, does it work? Then the third question is it worth it? And I realized that, having been a former NIH employee, almost everything we did at NIH was about that first question. It was about, can it work? So, tons of money spent on mouse studies. 70% of all NIH grants are either mouse studies or premised on mouse studies. And that, in fact, all the way through phase 3 clinical trials, those are really scientific questions. They test treatments under ideal circumstances. So the can it work is where we've put almost all of our effort. And then there's the does it work, does it work is, what FDA and others look at. And still, it's a lot of data are hidden and so forth. But then there's the third question, which is, after it's all done, is it worth it? And I realized that, a lot of things that we just spend money on without blinking an eye in preventive medicine and elsewhere, it's not so clear they're worth it. The USPSTF, when I was at ARC, we looked at all those things, and I sat in on the meetings, and so many of the things have tiny effects. Mammography, all-cause mortality doesn't really have much benefit. But the is it worth it question is, among 1,000 women who are screened, lots and lots, a high percentage of them will have something bad that happens, including perhaps an unnecessary biopsy. So when you take this question, is it worth it? It turns out that I think social determinants are the other end of that. It's clearly worth it. We will maybe get on the red line after we're done today, and there are these studies that show that the difference between being actually at Capitol Hill versus Shady Grove is a difference. I think it's like 9 years in life expectancy. We heard from the people from Chicago that it's 16 years between train stations. And Steve Wolf has this great graph showing that in Philadelphia, the difference between living next to the Liberty Bell versus the next zip code over 4 miles away is a difference in 20 years in life expectancy. So the question of, is it worth it? It's clearly worth it. I mean, way, way more worth it than these other things. The problem is we haven't answered those first two questions. So we don't quite know, can it work or does it work? And that it seems like what we really need to do now is double down on that investment in figuring those two things out.
A couple of thoughts. First is has to do with a diagram. It was kind of group effort putting it together as almost as a conceptual planning document to frame this day, and then it began to take on a bit of a life of its own. I think there was one comment that all the groups missed, and that is the color scheme. And no one recognized that the color scheme is blue and, what would you call it if you were a decorator, let's say? Blue and? Salmon, I heard. And of course, blue is the river, and salmon swim, fill it in, upstream. So I think there are multiple levels of meaning going on here that weren't even fully elucidated. So that's a teaser there. We talked a lot about down upstream. I think one of the comments that came out and that is true is that much of the discussion was from a healthcare perspective, and that is a bit how the day was framed. One of the things that stimulated the focus today was, as Sandy referred to in her opening comments, was this notion of medicalization and over-medicalization of thinking about population health and what really are the fundamental causes of health, of equity, and that they are not health care. And so is it becoming, in having a focus like this, are we falling into that pit or that trap and sort of hyper-medicalizing the whole thing? And I think what actually came clear today is that there is a lot that healthcare can do on its own, and then in partnership, primarily really in partnership, and in like a sort of true collaboration. Some really awesome examples of which we heard. There's a lot of energy towards health in the healthcare world. There's a lot of resources. There shouldn't be more. I think if we eliminated waste, there would be less. But I think we saw examples of it's both and. It's healthcare has a role and to greatly and a greater role to play in this space and in various ways without implying that the true that additional drivers of health in social and on the economic in terms of equity are not present and can be addressed in partnership with the other sectors. So I hope that came through. I felt that it did, and I think that's an important reflection for myself. The other one is really just about measurable goals. Josh touched on this, I think, in perhaps it was point 3 that you made. As work in this area deepens, it's just critical to name the goal that's being tackled and stick to it. So a really beautiful example of that is trying to reduce the gap in life expectancy by X% by Y year, as we heard from Rush and West Side United. I knew it wasn't West Chicago United, West Side United. So that is, I think that's because there's a lot of good ideas and there's a lot of things that feel like they should work, but sticking with measurable goals that, for example, tackle equity and health sort of in that kind of a combined way is, I think, a paradigm that we need to hew to.
Mylene Tufte with the North Dakota Department of Health. I really want to thank the roundtable and the planning committee because the tensions and the promise was just a beautiful description. I think one of the things that I hope is captured and maybe not emphasized as much today was around the technology, and I appreciated the Dr. Gottlieb around that hype of innovation, because I think some of the advances that we have today are around technology, and there's a lot of tension around technology and the advances and the expectations of patients and consumers, and then the kind of expectations around providers too about the electronic medical record and the expectations in documentation and expectations from payers, and then the documentation around metrics. So there's so much tension about what we're going to do with technology and how we're going to measure it. But there's a lot of promise too. So that technology, where we're going to go in the future with that is so powerful. And our governor talks about having a supercomputer in our pocket, because what we have in our smartphone gives so much knowledge to individuals, so much power, but it's how are we going to use that? So understanding that there is tension, but there's a lot of promise with technology. It has advanced us with what we can do with our health and being very directed. So if we could just quantify that for our day-to-day, that's something that's really advancing us from a population health perspective, and it's promising. Thank you so much.
So I'm AJ Diamantopoulos from the Denver Regional Council of Governments. And I've been trying to think about the importance of ROI. Let me rephrase that. I've been trying to get convinced that there is an importance to ROI. When I first started this, working in the community with social workers, ROI stood for release of information. I had a healthy education in that. When healthcare started, they didn't say, well, what's the return on investment of treating that disease? They said, my neighbor is sick. And I've been trying to think of this in terms of one section of an ethics course I took. And I realized that our healthcare system, and I could be wrong, is built, there are 4 basic principles: beneficence, non-maleficence, justice, and autonomy. Our healthcare system right now is built around non-maleficence and autonomy. But if we move into population health, it needs to be focused on justice, and it needs to be focused on doing the good thing. The ROI will come. There will be value there. It didn't start out that way in healthcare. It didn't start out that way in any industry. No tech company had made money for the first 10 years of its life, but they're all worth $1 trillion. It will come, but we have to focus on doing what is just and doing what is right for the person and the population we serve. So, thank you.
Ernie Hawk, MD Anderson in Houston. I wanted to just make 3 points briefly. The first one, I'll build off the last comment. I love that. I noticed it was one of the few comments that actually got applause. And I think that's because we're all inherently motivated to try. When you go into healthcare, it's all about trying to help someone. And so I agree with you that that should be part of the foundation that's kind of missing currently. And I think, at our campus, we've, we have large efforts to try to advance the quality of delivery of cancer care, and it's oriented around the old metrics of quality care. We've noticed that safety, timeliness, effectiveness, patient-centeredness, all of those are really emphasized, and we do a good job with all of it. The one that's difficult, I think, for healthcare systems to fully address is equity, and that's one that I think we should do a better job on each of our individual institutions, but it's also a responsibility of kind of government or large organizations that really have the public interest as its primary motivator. So I think that's one thing we need to concentrate more on. Second, I want to just highlight the importance of data. Every time we go out to do a new community project, we find that it's like a research study to try to gather sufficient data to measure the impact that you're having. And I don't think that's the best system. We would do better if we had a more inclusive and periodic assessment of behaviors, for example, that are strongly related to health outcomes that we're all trying to achieve. Because every time we find that we need to build the mousetrap one more time in order to collect the data that we need to measure. And it seems like there would be a better population-wide strategy, particularly in communities where the needs may be greatest. There should be more deep as well as frequent sampling there. And the third point I wanted to make was around incentives. And it's the last slide that I had that we didn't have a lot of time to cover. But we do now have incentives in place. I'm just not sure who's measuring them or comparing them. So in a cancer center's world, we have peer review every 5 years. So at least we're evaluated by our peers in terms of how well we're doing in community outreach and engagement. And that's a new program, just about 3 years since that was written into the guidelines for that program. The CTSA's been in existence about 10 years or so. They similarly have a peer review process where others are coming in and evaluating how well they're doing. So I think those are 2 steps in the right direction, bringing those institutions in the direction of population health with some evaluation. I don't frankly know who evaluates the 501c3 status on a periodic basis or the Affordable Care Act's requirement for community health needs assessments and particularly their coordination across institutions. And who might be evaluating those for their sufficiency, their actually changing metrics. And to me, those are systems that are already in place. I think we can do a better job in the peer review systems that exist now in terms of holding organizations accountable to those goals. But then I also wonder about those other things that we have in place where it seems to me there is no one really evaluating the impact of those programs when indeed they're intended to have an impact. So thank you very much.
Thanks. Just to say, one point, we looked at every healthcare system award program and whether they gave points for population health. And the spoiler alert is almost all of them gave virtually no points for population health. So.
Hi, Philip Alberti, Association of American Medical Colleges. To answer that question, the IRS is adjudicating, so we should all feel real good about that. I'll try to say this as politically as I can, but so something that's a tension, the biggest tension, I don't know if we've touched on, at least the biggest tension for me. So we've heard a little bit about it when MD Anderson was presenting and kind of couching, in the state where we live, kind of with all what that means. Our work group over here talked about gazing longingly across the pond for different models of how this is done. So, and we've heard about it in terms of threats to sustainability, how we keep it going, how do we get people on board, how do we build new partnerships. And I don't know the answer to this, and maybe this is not the right venue to say it, but I think I do think about the things that make us uniquely American. Right? What is baked into our nation that inhibits progress in this space? So I think of rugged individualism. I think of competition. I think of racism. I think these core principles that stand in the way of our having the kinds of effective coalitions, broad coalitions, bringing people together in service of all of our interests, doesn't always seem to be the orientation of we as Americans. And so maybe we need to do a better job communicating in ways that are appealing to others. Maybe it's stopping the work for a minute and having those conversations to understand, what do you want to get out of this? What is I talk a lot about selfish metrics. Forget the long-term goal, the health outcome, the equity metric. What do you personally hope to get out of this partnership? So how do we incorporate that into our evaluations to show that we can still be individualistic in the why we're doing this work, but still have the outcome be collective in some way? I don't know how to brook that, But I'm mindful that other places don't struggle with some of those issues and some of those histories in the same way that we do, and I think that's a big inhibitor.
I'm so glad that you said, that you reminded us that whatever gets said here goes in the notes in the report. I am reminded of a lesson that I try to tell myself every day in the way that I work with my team, and it is that privilege can be like a set of blinders, or it can be like a crowbar. So I would like to invite us to think about our privilege, because there's a lot of it in this room, as crowbars. Not for yourself, though. Not toxic individualism, to rephrase Philip. And I also want to just elevate this quote from Consuelo, who may be gone for the day, safe travels, that she looks to model within her institution the way that the world that she wants to see outside of her institution, right? So if we say that we want to address inequities in communities, can we look at how within an institution, what's the difference between the salary of folks in the C-suite versus the people that provide our food every day in the cafeteria? Thank you.
Excellent. Well, thank you. If you wonder why I left Lourdes' name tag up here the whole time, was it to just make sure she had the concluding comment? The answer is yes, that's why I did that. Excellent. Please, thank you all for your great comments, and we look forward to the follow-up from this session today. Have a great day.